Critical thinking and decision making. This is really what's going to set you apart from other healthcare professionals because we do this a little bit differently. We will make a diagnosis, we will do something called get a differential diagnosis, and we do it very quickly. And there are shortcuts that we'll talk about that will help you reach a diagnosis, a working diagnosis, so you can treat a patient. We're also going to discuss how we think more like emergency physicians than we do any of the other healthcare professionals. And so I'll show you how that comes about too. A diagnosis really is just a label for what we think is wrong with the patient. Now in the field, we don't have access to all the diagnostic tests that they're going to have in the hospital. We don't have access to all the treatments that they have. However, we do have a responsibility, though, to maintain our patients' ABCs. So regardless of the cause of the compromise of one of those, we're still going to have to manage the compromise. The best thing we're going to do is try to get a good history from our patient. History tells us so much and helps us project what may actually be wrong with our patient. And of course, vital signs are extremely important along with our physical exam. But history, when we can get it, what type of patients do we spend most time getting history on? Conscious medical patients. Those are most of our history gathering. A trauma, how much information do I really need from the patient to assess a trauma? If I've got mechanism of injury, I'm going to palpate everything. I'm going to figure out, pretty well what's wrong with them. Doing a diagnosis and critically thinking is going to involve a physical assessment of our patient, but it's also going to involve a lot of us putting the pieces together in our little brains. It is an intellectual activity. That's one of the things I like about this. We really can think through this process. It's very creative for us. How does a clinician reach a diagnosis? You guys would be clinicians. You are treating patients clinically. We're all going to have different levels of training. We're also going to have a lot of different experiences. I've come out of several very large EMS services, so my experience level is going to be different than somebody that comes out of a small service that doesn't see a lot of patient loads. Usually if you work in a rural area, your experience level is going to be much higher simply because you treat a patient for a long period of time. Whereas when you're inner city somewhere, like if you're right downtown in Atlanta, you can spit on 10 hospitals. So you can really get to the hospital very quickly, sometimes before your patient crashes on you. So it'll really depend on where you are, what your circumstances are, as to what your experience level is, as well as how long you've been practicing. I remember years ago when I finished permanent school and I'd been working in the field for a while, I asked one of my instructors, but how long does it take before you really feel comfortable with what you're doing? Every time the tones go off, you're kind of going, with what's it going to be? He says, it really takes about 2 years in a pretty high volume setting. And he was exactly right. It was about 2 years before I really felt like I could handle anything that came down the pike. 2 years is a long time when you're out there practicing. Every time you're going, what's it going to be? So based on how long you've been practicing, the circumstances of your practice, you're all going to be at different levels. So there's no expectation that when you guys leave here in December, you're just going to be wondrous, providers. It doesn't happen. You're going to be adequate. And then as you practice, you get better and better and better the more you see. So the more you've seen, the more you've done, the better diagnostician you're going to be. So don't set yourself up to be great at it. So there are a lot of different ways, different techniques that clinicians use to do their assessments. A physician in a physician's office, if you come to him because, you've got some chest congestion, what's he going to do? He's going to say, well, tell me about your congestion. Here, take some cough medicine. Call me when? When does he want you to call him back? Oh, yeah, next week sometime or the week after, but I'm really busy. Don't call me unless you're really sick. So their diagnosis really, they may do a throat swab, send something to, the lab or something like that. So you're not going to get this immediate, treatment and care and you're all fixed up. They have this long process. They may send you for tests for this and go see this doctor and do this and this. So it may take quite a while before you get your diagnosis. When you go to the ER, how quick are they? Yeah, they're still going to run some tests. They got to do that chest X-ray. You know, we're going to have to bring respiratory up here. So you may be talking about minutes to even several hours. How many of you guys have ever been into the ER? Oh, okay, as a patient. Ah! Y'all scaring me. I smell everybody in
You
here.
have to sit there for 2 hours.
Yeah, how long did you sit there?
2 hours.
2 hours.
Oh, I went right in.
You got to, how long were you there?
You went in my
Well,
ambulance, though, right?
Well, the first time, when I got bit by a dog and had to get rabies shots.
How long were you in the ER?
20 minutes.
In and out in 20
Yes,
minutes?
because
It's
I
one in East Alabama.
Yes, it was. I swear.
Wow.
Well, that must have been on Christmas
Somebody
Day.
must have called it a bomb scare.
I mean, we walked in there, I was like, all right, I need to get some rabies shots. The first time.
That was definitely Christmas Day.
4 hours.
4 hours?
o'clock things.
Yeah? How long were you there?
Another few minutes.
You were there for a long time.
Yeah.
Yeah. How long were you there? Are you there forever?
Last week, 7 hours before they
You're
saw
always,
us.
you're always there, yeah. Anybody else? You may be there a long time. They're gonna run a bunch of tests and stuff, but you're still gonna, you're probably gonna get your diagnosis quicker here than you are there. But with EMS, what's our time frame?
Boom. Now.
Yeah, like now, 5 minutes, 10 minutes, that's about all you got. So we have to be very quick, and we have to be very efficient, and we have to be really sharp. You know, it's hard to cover our sins. So the traditional approach to diagnosis is, as we were saying, like in a physician's office. They do an assessment, you know, they're going to talk to you, they're going to work up a differential diagnosis. A differential diagnosis means they're going to see several different things. It could be this, it could be this, it could be this. This is kind of like how you take a test. It's like a differential diagnosis. Well, it could be this, except that doesn't have a fever, so you mark that out. It could be this, except, you know, he's got green sputum, so that's not going to be it. So he's going to take things away until he narrows it down to it's probably this. And then they'll do some more reevaluation, do some more tests, and then finally they'll come up with a diagnosis. We will do a very quick differential diagnosis based on our experience and what we know within a matter of several minutes, without, sometimes seconds, without the assistance of lab tests and everything. In emergency medicine, we need to rule out life-threatening things very, very quickly. If it's not going to kill you, I'm not going to sweat about it. But now you go to the ER, they're going to see you and they're going to sweat you all up about a whole bunch of different things. But for us, if it's not going to kill you, I'm not going to worry about it too much. Our job is to stabilize the patient. Make sure your ABCs are intact so that you're not going to die on our watch. Turn to gather additional information. Yeah, if we have time, we'll get a bunch of other information, but we may not have that kind of time. We want to rule out, we're going to focus on the worst case scenario, something that we can hopefully do something about, but if it's nothing serious, we just don't get too wigged out about it. But we are always going to look for the worst it could be and hope for the best, because we don't want to overlook something in an emergency setting. We're going to learn to recognize red flags, and that means there's going to be little things that are just going to tip you off in your mind that say, problem, problem, you know, kind of like one of those little neon signs flashing in the night. The example I use a lot is tuberculosis. Did we talk about that in the one night? Okay. Tuberculosis. If you've got a patient, you go out in the middle of the night, and he's been coughing, and he's sick, and he's spitting up stuff, that could be pneumonia. I mean, it could be a lot of different things. But he says, God, I just wake up in the night and just sweating all over. And you're going, night sweats. And that says tuberculosis. That would be a red flag. Now, that doesn't mean absolutely that your patient has tuberculosis, but there's a really good chance that that's what that is. So that would be a red flag. So when I tell you to make those note cards and write down the signs and symptoms of every single thing, treatments for every single thing, then you will recognize those red flags. If you see it in a test question or you see it on a patient. I can tell you, because I've looked at just about everybody in here, when you go into that home in the middle of the night and that guy says he's got night sweats, what are you going to think? TB, ah! Yeah, because you will have recognized that red flag. So that's one of the things that we do. It's one of the ways that we get our differential diagnoses. We will recognize red flags, or they're like signposts that lead us in a direction. It's not always right, but most of the time it is. Okay, the way we approach our differential diagnosis, we have to be very efficient because we don't have that kind of time. We don't get second chances. If we've got a patient with an A, B, C compromise, any one of those compromises, we may not get a second chance. You know, if your knee hurts, how many times can you go to the orthopod with a hurt knee? Lots. Yeah, come back, take this, come back next week. You know, go and get some physical therapy, come back next week, you know, next month, next year. We have to be much more efficient than that because we're talking about life or death things. We have to get those patients turned over. Sounds bad, doesn't it? But we're not like a physician's office. We're not going to spend hours on a patient. We've got minutes and that's it. We got to roll. We also work in an uncontrolled environment. If y'all haven't been on any of your clinicals yet, and of course fall is a really nice time. It's usually not too bad, but we can have very changeable environments. I went to the beach for a long time. I don't know if you guys know that. And I remember one time we were going down one of those county roads to a wreck, and the reason there was a wreck because there was a tornado chasing this car, and these cars ran into each other. And we looked up, there's a daggum tornado coming right at us. So that was an uncontrolled environment. So it may be pouring down rain, it may be hurricanes, so we don't have the control that you're going to have either in a physician's office or even in the hospital. You know, in the hospital, what's the temperature? It's always what? 32, 34, kind of like in here. We also have limited tools available to us, tests available to us, and we also have a limited skill set. We don't do everything. I think I've mentioned that before. You know, I have people say, what do you think could be wrong with my blank? I don't know. Are you fixing to die? If you're fixing to die, we can talk about it. Otherwise, I don't know. We just have a very small slice, but it happens to be critical life or death slice. As I mentioned, we have a narrow educational focus. We're very, very good at what we do, but it is a narrow focus. It's kind of like we're specialists. We will go through the same steps as an emergency physician does. Once the nurse calls a physician in to see the patient, he's looking first the same thing we look for. He wants to rule out anything that's going to kill the patient. He's looking for critical, serious things. If it's not serious, it's not critical, he'll just say, do some tests and go on to somebody that is in need. But he'll do a very, I say he, she, will do a very quick assessment just to determine just what we do. You got anything that's going to kill you here in the near future? He's always going to look for the most serious things first. That's what he's trained to do. It's an emergency department, not, oh, I should have gone to the doctor 3 months ago. It's an emergency department. He's there to determine, is it got anything that's going to kill you? He's going to create a differential. Know that word, differential diagnosis. He's going to throw out the things that it's not, narrow it down to the things it can be. He's going to be looking for the most serious things first. Once you reach your diagnosis, your work is not done. Why? We figured out what's wrong with our patient, now what? We got to treat it. Yeah, just because we know what it is, if we don't manage that blocked airway or that inadequate breathing, then we haven't done our job. We have to be constantly looking for information. We learn a lot just through our senses. You know, we see patients, we hear patients, we smell things going on, we palpate. We use all of our senses pretty much, including our noses. Did I say that? Yeah, I did say that. Yeah, so we're going to use everything available to us to help us assessing our patients. Yeah. But you got to keep looking, you got to keep listening. There's something called heuristics. That's a word that I don't know, I have a hard time remembering myself. These are going to be little patterns that you're going to notice about patients. Like I mentioned, the red flags, they say one thing and it kind of rings a bell in your head that it could be whatever, this and so. You're going to recognize patterns in patients. Where patients with CHF, most of them will present with a certain set of symptoms. Patients with anaphylaxis, they usually present with a certain set of symptoms. So you will learn to recognize patterns. It's kind of like it looks like a duck, it quacks like a duck, it walks like a duck. It's probably what? A duck. Yeah, probably. It may not be, but it probably is. So that's going to help us narrow down our focus. It's going to help us start ruling things out. Is it absolute? No. But recognizing patterns in patients, some people are really good at that, some are not so much. But it helps us, it's a way of a shortcut to help us get to a diagnosis so we can get to a treatment very quickly. Because we don't have all the time in the world. It allows us to be more efficient and allows us to treat our patients much more quickly. But you have to understand our limitations today. We're not always right. Just one of the problems that we do because we have to make such quick judgments is it may cause us to narrow our focus and not recognize anything that doesn't fit our pattern. And that may be one of our downfalls sometimes. How can you learn to think like an experienced ER physician? If you're going to be good in this business, you have to be able to appreciate ambiguity. Anything that is different or just the inconsistency of what we do. If you have to have everything in a box just like this all the time, you're not suited to this because our environment is much too changeable. We have to know what our limitations are, our partner's limitations, our technology. There's a lot of tests I'd love to be able to do in the field, and we can't. You know, we just don't have the time, we don't have the equipment. So we just have to recognize that and do the best we can with what we've got. How do the limitations of technology impact an EMT's diagnostic technique? We don't have the equipment, so what are we going to use? Our eyes, our ears, our hands, our assessment. We have to be really good at it because we don't have these tools. And you have to make sure that the tools you do have, you don't let them interfere with you doing a patient assessment. If you put a pulse oximeter on a patient who's talking to you, he's alert and oriented, he's got good skin color, good capillary refill, no problems with mental status, everything's all good, his ankle hurts, and you put a pulse oximeter on there and it says his O2 sat is 64. What are you going to do? You're going to start bagging him? Are you? He's got a pulse ox of 62. 62%, that can kill you. Treat your patient, not the equipment. Obviously, the equipment is malfunctioning. Treat your patient, not the equipment. What if you had a patient that was semi-conscious, he's been throwing up, he looks horrible, and you put the pulse oximeter on there and it says he's 100%. Well, it could be right, he's got carbon monoxide poison, but it could be wrong. Or it could be, it doesn't matter, maybe he's got 100% right here, but he's got some issues, you're going to put him on oxygen. So don't let technology limit you. We're going to use a lot of different methods to do an assessment. Sometimes most of our assessment is going to be what we can glean with our hands. What circumstance would that be? Maybe a trauma. If you're sitting up here telling me that you have a stomach ache, am I going to get most of my information from palpating your whole body? No, where am I going to get most of my information? From talking to you, yeah. If you're unconscious and you're bleeding and all broken apart, how am I going to get my best information? Yeah, with my hands. So you're going to use whatever method is going to be most appropriate that you're going to get the most information from. So no single way is always right. That's one of the things that I do like about this profession is you're each going to be able to bring your own technique and your own special skills to the practice of this form of medicine. So everybody's going to do it a little bit different, except when you're in EMT class. Then everybody does it the same. But once you get out there and practice, you'll develop your own techniques for things, and that's nice. You have to stay open-minded. If you get that tunnel vision, and it's easier to do at both ends of the spectrum. When you're new, you get tunnel vision because you're focused on, well, if it says this, then it must be this. At the opposite end, after you've done this for 100 years, you get lulled into this sense of, I've seen this 100 times, I've got this, and then something's going to jump up and bite them. So you got to stay open-minded. Hey, and really take the time to talk to your coworkers, talk to other healthcare professionals, and just suck their brains dry. You will learn so much by talking to other people and learn how they handle similar situations. I know I used to, when I would work with a new partner, I would always ask them after a call, was there anything that you think we could have done different? What did you think about the way we handled this? And just having that dialogue kind of opens your mind to other ways you can do things, and maybe you overlooked something. So always be ready to learn from other people. Always make sure you've got a good foundation of knowledge. That means you know that textbook. That means if you move on through the program, you know all of your algorithms. Make sure you know those sheets, because then you'll be practicing from a position of strength. You'll know what you need to know. But if you don't have that foundation, you're going to be out there and it's going to be scary. Real scary. Your note cards, make sure you're familiar with just about any condition that we talk about in here. So you've got that foundation. Because if you don't, when you get thrown out there and it's a really scary situation, you're going to be stressed, you're going to be breathing about, 30, 40 times a minute. Your pulse is going to be running at about 140. You're going to be scared. So you need to have that foundation so you don't have to be frightened more. Make sure you stay up to date. They're constantly changing how we treat patients. Probably just 3 or 4 years ago, and for about the 15 years before that, we didn't use a tourniquet. It was considered last resort. You had one on the truck, but you didn't use it. You tried 15 or 20 other things before you put on a tourniquet. Prior to that, we always used a tourniquet, but about 3 years ago, they changed it, and now that's on bleeding and shock. And you put on some direct pressure, put another bandage, and then what? Tourniquet. If you can't get it to stop bleeding. So things are always changing, so it's important, and it's incumbent upon you to make sure you are reading and you're staying up to date. This is not like math. Math never changes. This stuff changes all the time. Okay, you got to be organized. Remember, I told you, you have to learn these sheets. Why do I make you learn these sheets? So that you are organized. If you've got this in your memory bank, you've got this as your foundation, it's going to be a lot easier for you. Because most of your scenes a lot of them are going to be chaotic. There's going to be a lot of things going on, so it's important that you're organized. What are some of the important things to remember as you learn how to make a diagnosis and improve your critical thinking skills? Y'all are going to have to think about that one. Routine diagnosis is a process. Okay. Don't let a diagnosis attempt delay your patient care. I may not know why he has inadequate breathing, but what can I do? I can manage it. So it may not be necessary to know exactly why that's the case, but I have to recognize that it is the case. If he's got inadequate breathing, I have to recognize inadequate breathing. I have to manage inadequate breathing. I may not know why he has inadequate breathing. So diagnosis is good, but the important thing is the assessment and the recognition. Okay. We make diagnoses in the field. They're not extensive or as detailed as a physician would be. The traditional approach to reaching a diagnosis is assess the patient, draw up your list, assess them some more, narrow the list, just kind of a give and take. We don't have that kind of time. Experienced physicians don't use that traditional approach. That's more what you see in a physician in a office setting. They're going to use, in the ER, they're going to use heuristics based on what they've seen and what they know. They're going to recognize patterns. What are the limitations of heuristics?
You may get something.
Yeah, you get tunnel vision. You think it looks like a duck, quacks like a duck, walks like a duck. It's a swan. I don't know. Yeah, so you get tunnel vision. Learn to think more critically by looking for ambiguity. Look for things that don't fit. If there's one little niggling thing out there that doesn't fit, then you have a problem there. Don't search for a diagnosis and not treat your patient. Critical thinking is an analytical process. And that's one of the things that we're hoping to move you through here. We give you a set of facts. As we move through the semester, you're going to learn to think critically. I'll ask you questions in the lab to make you think about why that patient is in that setting. You know, what are we gonna do about it? It goes beyond just memorizing a set of facts. You've gotta be able to think, and reflect, and do something with it. You have to be very efficient, but very accurate. Patients will very frequently have more than just one thing going on. If they say they've got chest pain and you think you've got a diagnosis, don't quit looking. Keep looking. You may come out with something else. I gave you the example of the patient that had open heart surgery a couple weeks prior. The paramedic treated him for chest pain, heart attack the whole way, and it turned out to be a sugar problem. I told you guys that, right? Yeah, it was a friend of mine. The patient was 2 weeks post open heart surgery, and she called for chest pain. He treated her for chest pain. He gave her nitro, aspirin, oxygen, the whole bit. Transported her up to the hospital. One of the first things the staff did there was check her blood sugar, and the doctor says, "Well, she had a blood sugar of 38." Well, no, he never looked. He didn't check. They gave her some sugar. She was fine. She had a full recovery. It was a blood sugar problem. It wasn't a heart attack. So don't stop looking. All right, you've got a 52-year-old man who complains of chest pain while he's sitting at his desk at work. He appears alert and oriented. He tells you he thinks it may just be stress. How would you arrive at a diagnosis? He says it's stress. You're immediately going to think what? You're going to look for the worst case scenario. If you go with, yeah, this probably is just stress, and he's having a huge myocardial infarction, and he falls over dead right in front of you, how are you going to feel? Treat the guy for stress. You're always going to look for the worst case scenario and work back, right? All right, let's see. How will you arrive at your diagnosis? Oh, yeah. Flip a coin. Is it stress or is it chest pain? Okay.